Hey everyone, and welcome back to the Master Oral Pathology channel. Today, we're diving into a really critical clinical review of severe opportunistic fungal infections. Specifically, we're going to be focusing on mucormycosis and aspergillosis. You know, as future dental professionals, you are quite literally on the front lines of detecting oral and maxillofacial pathology. Now, sure, you're going to see countless routine lesions in your careers. We're talking fibromas, simple ulcers, the usual odontogenous cysts, but there are certain aggressive, fast-acting infections that absolutely demand immediate, urgent recognition. Missing these? Well, it doesn't just lead to a delayed treatment plan. It could literally cost a patient their life. So today, we're going to thoroughly break down the etiology, the clinical presentation, and the crucial histopathology you need to know, not just to crush your board exams, but for your future daily clinical practice. Okay, let's dive into this with a scenario that really highlights the terrifying clinical reality of this disease. I want you to picture a patient sitting right there in your chair. They've got a history of poorly controlled diabetes. They come in complaining of severe, unexplained palatal pain and this rapid unilateral facial swelling. You do your exam and you see a massive necrotic ulceration that looks like it is literally eating through the roof of their mouth. Just take a second and let that clinical picture sink in. What opportunistic invader thrives in ketoacidotic diabetes and can cause a massive palatal perforation in a matter of days? Well, the answer lies in a group of organisms that are entirely harmless to a healthy person, but absolutely devastating and often fatal to an immunocompromised host.
To get a really solid grasp on these infections, here is our roadmap for today's session. 1. Etiology and pathogenesis. 2. Clinical features. 3. Histopathology. 4. Differential diagnosis. And finally, 5. Treatment and prognosis.
All right, part 1, etiology and pathogenesis. Let's set up the scene of the crime. First things first, we've got to define our causative organisms. When we talk about these severe fungal infections, we're really dealing with two main categories. First up is zygomycosis. Now, this is a pretty broad clinical term referring to infections caused by several fungi in the Zygomycota group. When we're talking about the head and neck region, the clinical disease known as mucormycosis is typically a sinonasal infection caused by species in the Mucor, Rhizopus, and Absidia groups. And believe it or not, these are just your common everyday bread mold fungi. On the flip side, we have aspergillosis, which is caused by Aspergillus. This organism is absolutely ubiquitous in our environment. I mean, these spores are everywhere. They're in the soil, in decaying vegetation, they're floating around in the dust in our homes. We inhale them every single day. And the thing is, they're harmless to the vast majority of people. A healthy respiratory tract with its macrophages clears them out no problem. But they're patient. They're just waiting for the perfect opportunity to strike the second those defenses fall. And that brings us to the absolute most critical aspect of their etiology, the host environment. So the crucial point here is that these infections almost exclusively target patients with severely compromised immune systems. Like we said, an intact immune system clears these spores with ease. But think about the predisposed states. We're talking about patients with poorly controlled ketoacidotic diabetes, immunosuppressed transplant recipients, folks battling advanced malignancies, people undergoing heavy systemic steroid or radiation therapy, and those living with HIV and AIDS. Now, let's talk about ketoacidotic diabetes for a second because this is a massive high-yield concept for you to remember. The altered serum iron levels and the highly acidic environment in these patients literally act like fertilizer. That acidic state actually unbinds iron from transport proteins like transferrin, and these specific fungi, they absolutely thrive on that free serum iron. It supercharges their growth and leads to massive tissue invasion. So, once that opportunity presents itself, how exactly does the infection progress? Well, the route of infection usually goes through either the GI tract or the respiratory tract. For the head and neck presentations, which is what we as dental professionals are obviously most concerned with, it's usually direct inhalation right into the upper respiratory tract. But step 2 is where the nightmare really begins. These fungi have this terrifying ability for arterial wall invasion. We call this angioinvasion. They literally penetrate and invade the endothelial lining of the blood vessels. This leads right into step 3, hematogenous spread, and the deposition of fibrin, which creates blood clots or thrombosis, right there inside those vessels. And step 4, that's the inevitable devastating result. Think about it. When you thrombose the blood supply to a region of tissue, that tissue dies. This massive tissue necrosis, or infarction, is the absolute clinical hallmark of the disease. The crazy amount of destruction you see is entirely driven by the fungus choking off the local blood supply. Moving right along to section 2, clinical features, the investigation. In the head and neck, the presentation of mucormycosis and aspergillosis is heavily concentrated in the upper respiratory pathways. You're primarily going to find these lesions in the nasal cavity and the paranasal sinuses, especially the maxillary sinus, with potential extension drifting down into the oropharynx. Now, systemic spread to the lungs and other internal organs definitely happens, and it carries a really poor prognosis. But as dental professionals, your primary zone of investigation includes those nasal and sinus regions, and how infections that start there can physically manifest right in the oral cavity. Very rarely, you might even see a purely periodontal presentation, though I should note that's almost always tied to profound underlying immunosuppression like severe neutropenia. You have to understand that clinical progression here is rapid, it is aggressive, and it is deeply, deeply destructive. It generally kicks off with localized, sometimes kind of vague pain and swelling in the maxillofacial region, but that swelling rapidly gives way to surface ulceration. Because of that arterial angioinvasion and thrombosis we just talked about, the tissue isn't just getting inflamed, it's undergoing ischemic death. Massive tissue necrosis ensues. If this goes down in the maxillary sinus, that necrotic destruction can literally melt away the bone and soft tissue. And what does that leave you with? A dark clinical perforation right through the hard palate. But it gets worse. It doesn't stop there. The sinus is just millimeters away from vital structures. A really frequent and lethal complication is the upward extension of this necrotic infection straight into the orbit of the eye, which causes blindness, or directly through the cribriform plate right into the brain cavity. Seriously, take note here. This acts in days. Not weeks, not months, days.
Okay, Section 3, Histopathology. Let's dig into the microscopic clues.
When you examine a biopsy of this tissue under the microscope, you are essentially looking at a microscopic war zone. On one side, you've got this massive necrotic destruction of the host tissue. You'll specifically see these necrotic, dying vessel walls that are completely choked with intraluminal thrombi and just packed with invading fungal organisms. Now, in response to this full-scale invasion, you're going to see a host inflammatory response made up of an acute and chronic inflammatory infiltrate. But here's the really critical physiological contrast to understand. The body is desperately trying to fight off this fungus. It's sending in neutrophils, it's sending macrophages. But because the host is already deeply immunocompromised, maybe their neutrophils are totally defective because of uncontrolled diabetes or they're depleted from chemotherapy, this inflammatory response is just completely inadequate to halt the rapid necrotic spread caused by that vascular invasion. Now, what's really interesting here is a specific morphology of the fungus itself. Guys, this is pure board exam gold right here, so pay close attention. The organism is readily identified in standard H&E stained sections, and it's usually concentrated right in the areas of severe tissue necrosis. Mucormycosis is definitively characterized by hyphae that are large, pale staining, wide, and flat. Crucially, they are non-septate. That means they lack those internal cell crosswalls, which kind of gives them this unique ribbon-like appearance. And here's the kicker. They have a highly characteristic tendency to branch at right angles. Let me say that description one more time because it's that important. Wide, non-septate hyphae branching at right angles. Whenever you see that specific phrasing on an exam, or you hear an oral pathologist describe it on a biopsy report, your immediate, unequivocal thought absolutely must be mucormycosis.
All right, Section 4, Differential Diagnosis. Let's take a look at the lineup.
Let's walk through these high-yield differentials. If a patient comes in with a massive, destructive, perforating lesion on their palate, what else could it be besides mucormycosis? Having this mental lineup is crucial because, honestly, misdiagnosing here can be fatal. For example, historically speaking, you definitely have to consider the gummatose necrosis associated with tertiary syphilis. You also critically need to think about autoimmune conditions like Wegener's granulomatosis, which is known as granulomatosis with polyangiitis. Listen, if you mistakenly diagnose mucormycosis as Wegener's and you prescribe systemic immunosuppressive steroids for it, you will accelerate that fungal infection and you will kill the patient. Another rare but really critical consideration is midline granuloma, which is an intensely destructive NK/T cell lymphoma. And finally, aggressive nasal malignancies, things like squamous cell carcinoma or a salivary gland adenocarcinoma that originated deep in the sinus can erode right through the palate as well. The key clinical differentiator for mucormycosis, of course, is that severely immunocompromised host profile combined with the hyperacute, incredibly rapid onset of symptoms.
So how do we definitively prove which of these conditions we're actually dealing with? Well, a definitive diagnosis absolutely requires identifying the fungal organism in biopsy tissue, examining the purulent exudate, or getting a positive microbiologic culture. You can't just guess based on how it looks clinically. However, I have to stress a very grim reality that's outlined in all our pathology texts. Because of the extreme severity of the underlying immunosuppressive diseases these patients are already suffering from, and the incredibly rapid tissue-destroying course of this particular fungal infection, the definitive diagnosis of mucormycosis is tragically sometimes not made until a postmortem examination. The disease simply outpaces our diagnostic process if we aren't highly suspicious and extremely aggressive from the very first moment that patient sits in our chair.
And finally, Section 5, treatment and prognosis. The verdict.
The treatment for these opportunistic fungal infections cannot be passive. It cannot be strictly observational. It requires an immediate, extremely aggressive, multi-pronged strategy. The pharmacological drug of choice here is high-dose, systemic, lipid-based formulations of amphotericin B. Using that lipid formulation is absolutely crucial because it's less nephrotoxic, which allows us to use the massive doses actually required to fight the fungus. But remember the pathogenesis we talked about earlier. Medicine alone cannot reach a fungus that is hiding inside heavily necrotic, dead tissue that is completely devoid of a blood supply. The drug just can't get there. Therefore, extensive and often severely disfiguring surgical debridement of the upper respiratory tract, the sinuses, and the maxilla is frequently required. You have to physically cut out the dead, infarcted tissue to remove the fungal burden along with it. In some select critical patients, we also utilize adjunctive treatments, things like hyperbaric oxygen to promote wound healing, alongside recombinant cytokines or granulocyte transfusions, to try and temporarily boost the patient's severely failed immune system.
Despite all these massive, aggressive pharmacological and surgical interventions, we have to be absolutely honest about the prognosis here. As the pathology literature states very clearly and soberly, death is a relatively frequent consequence of this infection. The ultimate survival of the patient is intimately dependent on two main factors: the severity of their underlying systemic disease, whether that's uncontrolled ketoacidotic diabetes or end-stage AIDS, and exactly how rapidly appropriate targeted therapy is instituted. Now, while systemic dissemination down into the lungs is generally more globally lethal than isolated upper respiratory tract infections, make no mistake, a massive sinonasal infection extending upward into the brain cavity carries an incredibly high and incredibly rapid mortality rate. So as we wrap up this clinical review here on the Master Oral Pathology channel, I really want to leave you with a provocative challenge. Someday, maybe soon in your career, a poorly controlled diabetic patient is going to walk into your clinic presenting with unexplained palatal pain and unilateral facial swelling. At first glance, it might just look like a terrible endodontic toothache, or maybe a simple periodontal abscess. But armed with this clinical knowledge we just discussed, will you look closer? Will you recognize that rapid clinical progression, order the immediate life-saving biopsy, and identify those wide right-angle branching hyphae in time to alter their fate? Your ability to seamlessly connect these clinical and microscopic dots quickly is exactly why mastering oral pathology is so deeply critical to your profession. Keep studying, stay vigilant, and I'll see you in the next session.